Test, test. Test, test.
But I don't need the handheld though. Thank you.
Really midlife crisis and dark hair. Where did you get that from?
When we were doing the virtual class.
Oh my goodness.
We were going to put that on your production board.
Right, ready to start. So welcome to everybody here in East Surrey Hospital and those of you who are joining us online. This meeting and the proceedings will be recorded, and so if you have any technical difficulties, those of you who are online, please bear in mind that we'll be uploading the full recording in due course and you'll be able to view it on our website. So the purpose of today's annual general meeting of the Surrey and Sussex Healthcare Trust is for us to share with you a few reflections on the past year and also to share with you our annual accounts. We'll be telling 3 clinical success stories. One of them will be about our endoscopy services, one around the frailty same-day emergency care unit, and the third one about our improvement journey with SASH Plus and our digital teams. So without further ado, I'll now hand over to our Acting Chief Executive, Paul Simpson.
Hello, my name is Paul Simpson. I'm the Acting Chief Executive until the 1st of September when our new Chief Executive, Andrew Hines, will be in post. But welcome to our annual general meeting. I'm going to talk about the Trust and what we achieved in 24-25. And behind me, you can see some of the detail of the figures that we have to support what we've been doing. We are a very busy hospital. We have a catchment area which covers about 750,000 people. That's nearly as much as Devon and Cornwall combined, I believe. And because there are no hospitals really close to us, we have a large number of patients that come to see us. some of those numbers are up there. So nearly 500,000 outpatient appointments. That's one of the reasons we've had to make our car park a little bit bigger so we can fit everybody in. We have a very large number of emergency patients coming to us, 48,000 admissions over the year. We see between, 320 to 420 people in our emergency department every single day of the year. We are very busy. We do more emergency work than we do elective work, which is planned admissions, although we do quite a lot of that. That's 51,000 planned admissions that we had in the year. So, next slide, please. I'm going to talk about some of the things that we've done in 2024-25, and sometimes we forget actually about what we've managed to achieve. And we have done a number of things in the year. We have improved our cancer care, and we have delivered really strongly on a number of our cancer standards. That's faster and reduced wait times for patients, especially in breast cancer. You're going to hear a bit more about this from Michael and Sinead shortly, but we have introduced a frailty same-day emergency care SDEC unit, which allows us to treat patients in a different way and a better way. They will talk more about that. That's helped us to reduce the length of stay, the amount of time that people spend in the hospital who have been admitted because of emergency care conditions. And we've made some significant operational changes to the hospital, including closing Tilgate Annex, and we've reconfigured all of our medical wards so that they are better suited and better structured to deal with patients. Winter is tough for us with that catchment area and that population, and we have dealt, I think, very effectively with that. We've had our issues, but our planning, we have just completed our winter plan for the coming winter. We did the same thing early last year as well. We were well prepared, and we dealt with those winter pressures well. Next slide, please. More. So we're expanding our community diagnostic work. There's a national programme which is setting up community diagnostic centres off of trust sites. And so we've expanded that work as we've gone through the year at Crawley, and I'll come on in a second. We're opening a new service shortly in Red Hill as well. There's more work to do at Crawley, which will be completed in the next 18 months or so. We've improved our maternity services, and we're one of the top performing organisations in the country for standards of care, governance and learning in those services. We've introduced something called the Call for Concern, which is Martha's Rule, which again is working very well. That's where you seek a second opinion in respect of the care that's provided by somebody. And we've won a National Maternity Stream of Sanctuary Award as well. We've launched our first digital care pathway for skin and pressure ulcer prevention. And that was in response to a particular, so we identified an issue in the trust that we had with pressure damage. And so we took a number of steps to improve the quality of our care, and that's one of the outputs that came from it. For many of you, one of the main bugbears of people coming here, particularly for a blood test, was the queuing and the way it worked in our phlebotomy service, which is where the blood tests were done. So we built a new area which is much more convenient for patients at our east entrance, and I believe that is working very well. It's also gone online. So that's making, so you can book, and it makes it rather better, and somebody's given me a thumbs up there, so that's obviously a popular one. Thank you. We've invested in our teams as we've gone through the year as well. So we're a people promise exemplar organisation, and although our staff survey results were not as good as they have been, our number of vacancies have reduced as we've gone through the year. We've launched a new 24/7 Freedom to Speak Up Guardian service. Again, that's in response to what people have said in the staff survey. We used to have a part-time guardian. This is somebody that members of staff can go and speak to if there are issues that they experience or see within the organisation. But we only had somebody who was part-time. We've now got a service which is 24/7. That doesn't mean there's one person that's working all the time, but we do have a focal point who's called Trish, by the way, and she is making herself very known across the organisation as I say this. We've launched a new EDI framework, our Equality, Diversity and Inclusion framework, and that was recently. We've got a new nursing and midwifery strategy. We've launched the Primrose Awards to recognise our allied health professionals. And we've had a rapid process improvement workshop event to streamline and make our achievement reviews, which are our appraisals that we have about our performance, more meaningful. So we've done all of those things. Asha, next slide, please. We're also working very closely with our partners. So the new NHS is about integrated care and integrated care systems. And it's really important that this trust works effectively with all of the other bodies that are providing care or aspects of care that relate to what we do. So we are doing more in that area. We're working particularly with Surrey Heartland's Integrated Care Board. There's also a provider collaborative, and that's where we're working with the other providers, particularly the other acute trusts within the patch, which is the Royal Surrey, Ashford St Peters, but also Surrey and Borders Partnership, which is the mental health trust in the patch as well. We are also unique, so that large population is split 50-50 between Surrey and Sussex. So that makes our lives quite complicated. I have to go to twice as many meetings, perhaps, but it also means that there are differences in the kind of care that is delivered in the respective areas. So we're working hard, and we're helped by Sussex, by NHS Sussex and NHS Surrey Heartlands in doing that. And we're working closely in how we implement the aspects of the new 10-year plan, developing neighbourhoods so that we can bring care closer to communities and make sure that population health improves and outcomes for patients are better. Next slide, please. More areas we're making progress on as well, which is elective care. You're going to hear about our 5-year JAG accreditation from Alan, I think, later. We're improving our patient experience and other patient safety response. We've got new systems, the PACS picture archiving and communication system, which is the computerized way which we store diagnostic images in. That's been introduced as we've gone through the year as well. We have changed what's happening in Boots, because Boots was an issue for us in terms of the queues for patients. And that has meant we spent a year preparing for that. We've renegotiated and agreed a different way of doing it with Boots. And we're hoping that that will provide a faster service for patients, a better service for patients in terms of the outpatient pharmacy it is intended to be. I've mentioned the CDC, the Community Diagnostic Centre in Red Hill. And we've launched a new birthing options video to help support patients and families expecting babies. And I'm going to take a breath now, and I'm going to hand over to Michael and Sinead. There is a third person in that picture, which I think is Ian Wilkinson, but he's not here. Michael, if I hand you the microphone, please tell us about the SDEP.
Thank you, Paul. Yeah, really looking forward to explaining to everyone today what we've done over the past year or so to improve outcomes for frail and older people. But before we get started, we just wanted to introduce ourselves. My name is Michael Wyatt. I am the Associate Director of Clinical Pathways at SASH.
And I'm Sinead Henderson. I'm the Clinical Lead for Elderly Care. My colleague's on holiday, which is why he's just a spectre behind us.
So we just wanted to outline to all of those in the room and those that have kindly joined us online and at home as well, some of the work that we've done since 2024-25 to improve outcomes for frail and older people. Before Sinead explains what it is exactly we've done, and then we talk through the impact it's made, we just wanted to explain the backstory as to why we chose to focus on this. Last year, the Trust, from board down to ward, made a commitment to improving outcomes for frail and older people. And we did this because we knew there was an opportunity for us to do so. We were a bit behind the curve based on the national guidance and expectations on what we as an acute hospital should have as an acute pathway for frail and older people. Now, Sinead will explain that a little bit more, but that means having a same-day emergency care unit to prevent admissions. It means having early identification of frailty within the emergency department. And because we didn't have that, it meant that if you were an older or frail person that attended East Surrey Hospital as an emergency attendance, you would be more likely to be admitted than if you went somewhere else. If you were admitted, you'd be more likely to stay a little longer than somewhere else. And as a result of that, and the consequence of having inpatient stays as an older and frail person at a significant risk of deconditioning, you're actually less likely to then be discharged back to your own home. Now, that's really significant because someone could have come into hospital at age 75, having lived at home for all their lives, and then they never go back there. And there's an opportunity to do something differently about that. And we wanted to make sure that we did. So there was a commitment that something had to change. We made that commitment. We've seen it through, and we're going to explain to you a little bit more now about what that looked like.
Thank you. So as Michael said, we'd recognised there was a need for change, and it wasn't a small need for change. It was something that was going to be a bigger piece of work. It wasn't something we could achieve on our own. We had to look at our community partners and think about how could we work within the system differently. And for anyone that's ever been in ED or worked in a hospital, we'd noticed a while ago that we had an increasingly frail population coming through our emergency department. And that patient population is at a much higher risk of developing a delirium. That then impacts on your length of stay and then has a significant impact on how you're discharged from hospital. And we needed to make a really big change to work differently. And it was easy to recognise what we needed to do. We needed to identify people much earlier in the emergency department. We needed to impact on their management plans much earlier. And therefore, we needed to discharge them earlier, which all sounds really simple. But how do you actually do that? Well, last year, at the same time as we were recognising this and looking at figures, we had the opportunity, because the community were developing virtual wards. So it gave us an opportunity to do something very differently within our trust, but increase how we promote working within the community system. And it was a real opportunity for change. We also needed to adapt what we were doing to keep in line with Surrey Heartlands, especially from the frailty work that Michael was talking about, specifically about creating a frailty SDEC. We've got a really successful acute medical SDEC, but it's slightly different for frail patients. You have to be frail enough to be admitted into the emergency department, but you can't be so frail that you need to be looked after by a nurse 24 hours in a bed. So there was a very small middle ground of opportunity of patients that we could bring into a shared area with the right multi-professional team, therapists, doctors, nurses, ward clerks, the whole team that we need to look after this patient population. So we talked about how can we begin this journey, but how do we do it within resource, which is always the big challenge that we're given, which is fine, no problem. So we thought, how do we collect data? How do we work with the managers? How do we work with the exec team? Realistically, telling them what do we need from them, and how can we actually affect some change? It's my team, so I'm heavily biased, but the elderly care team is, of course, it's a really proactive and dedicated team. They're really flexible. We've undergone a huge amount of change in the last year, and I think it's really down to their dedication that we've been able to achieve what we've done, and they really are fantastic. So we took a leap of faith. We knew what the data said, we knew what the models said, and we knew what ought to happen, but we weren't really sure if it was going to happen. So we had to take a leap of faith, working with the exec team and obviously the board, and we repurposed an area. We took a whole 6-bedded area out of commission and put chairs in it, which in any acute trust is a big decision to make. We repurposed a cupboard for an office. We're very good at that in the NHS. And we really changed our presence within the emergency department. We started that off in about April time with earlier identification, getting the data, looking at the figures, looking at the patients, thinking, is this definitely the right thing to do? In October of last year, we opened the frailty same-day emergency care unit. This was all within the current staffing level, so we had to repurpose clinical time. We had to flex up how we were delivering that service. And we are roughly seeing between about 6 and 10 patients every day, the vast majority of which we are discharging home. We had to prove the concept, prove that it would work, start that new way of working, create a new name. So the team came up with Gemini and called it the Gemini service. And then Michael will tell you about what we've actually achieved.
Mm-hmm. Thank you, Sinead. So the numbers on the screen kind of speak for themselves. We had 3 primary objectives we wanted to get out of this work, ultimately, when we talk about improving outcomes for frail and older people. Reduce avoidable admissions, reduce length of stay for those that need to be admitted, and for those that are, help more of them get home. That's exactly what this team have been able to do, and the extent to which they've done it is remarkable. So of the patients that have gone through the SDEC, there's been about 1,000 that have gone through there. 70% have gone home the same day. Now, most of those patients were at significant risk of being admitted. As Sinead said, there's that grey area of will they or won't they? And without this service, there's a really big chance they would have been. Of those that did, many more were going home within 3 days compared to before, and the average length of stay of all patients had gone down. Because of that, more people had been able to go home instead of going into a long-term care placement like a residential or nursing home. Now, before our acute Gemini trial started, there was a cohort of patients, which was kind of what we called our baseline. So before the trial, 6 out of 10 patients at that point were going back to their own home. So 4 out of 10 weren't. Of the patients that Gemini saw, 9 out of 10 went back to their own home. So that's 90% compared to 60%, which just shows the importance of getting this stuff right. Not only that, though, we've been looking at the quality measures at the same time to make sure they're not inadvertently causing any harm. Of the patients that have been discharged sooner or not been readmitted, there haven't been an increase in readmission rates, and our mortality in hospital for this cohort has actually reduced at the same time. Now, Sinead talked about doing with this in resource. We can't underestimate how significantly challenging that can be for staff, this level of work. But when we've got it right and the multi-professional team work together and get these sorts of outcomes, again, the feedback from the team has been really, really positive. They enjoy doing this sort of work. It gives them the joy that they have as being clinicians by improving outcomes for these sorts of people. So this really has made a massive difference. We've moved from that kind of bottom quartile in the country to middle, but because we're middle, we're not quite done yet. There's a few more things we want to do, which is how we're going to close with Sinead talking through that bit.
So we have made some changes to enhance the frailty front door model. We've adapted how the entire department works. As of 10 days ago, we now have a full Gemini service where we have a 5-day same-day emergency care unit for frailty running. We have taken back the post-take ward rounds for older patients. So what that means is that elderly care physicians are now doing the full ward round every morning in the emergency department. So that helps with the earlier identification, getting patients in the right place, right care, right time. We are working through the details of how we're managing that. There's obviously lots of different models, and we're trying to make sure that we embed this service to maintain resilience within the clinical team, because it has been an absolutely huge change. We have increased our acute bed base as part of this by about 19 beds to really improve the focus of patient flow, reducing length of stay, and making sure that clinical attention every minute of the day is absolutely there for all of our patients. The next steps, other than just embedding the small change in service, maintaining resilience and the staffing changes, is we can start working towards a 7-day, same-day emergency care unit. Certainly nationally, we need to make sure we're up there with the rest of our local providers. We need to think about how we can get direct referrals from GPs, from the ambulance crews. How do we smooth through that pathway? How do we help improve things even more in the future? And again, very importantly, how do we carry on working with our system partners? So we need to look at our neighbourhoods, the future neighbourhood teams that I'm sure a lot of you will have heard about. We are very involved in that development, but we need to make sure that we continue that support right through from advice, guidance, support to community teams, but also thinking how we can communicate and how we can get patients out of the emergency department, out of our hospital as soon as possible, back to the communities to carry on with their care. So thank you very much for listening. We are going to hand over to Alan James, who's going to tell you about all the exciting endoscopy work.
Thank you. Put that the right way around. My name's Alan James. I'm a consultant surgeon and I'm the clinical lead for endoscopy. Endoscopy refers to examining within, usually with a flexible camera. Any system that has an exit or an entry point in the body, we can probably get to with that. That's not a threat, that's just a capability. The most common use of endoscopy is in the GI tract or gastrointestinal tract. The upper gut is looked at with a process called the OGD, or esophagogastroduodenoscopy, often shortened to gastroscopy. Lower tract is looked at by colonoscopy. And endoscopy is one of the important diagnostic modalities, along with imaging like CT and MRI, in which there is a lot more, an increasing interest because we are aiming to try and principally diagnose cancer at earlier and earlier stages in order to improve cancer survival throughout the UK. At SASH, we do about 15,000 endoscopies procedures per year, mostly of the GI tract. We have 26 endoscopists split between gastroenterology, general surgery. We have specialty doctors, a nurse consultant, and a nurse endoscopist, and one in training, so quite a few. And this is in 6 rooms, with 4 at East Surrey and 2 at Crawley. Endoscopy services are accredited by the Joint Advisory Group, which was set up in 1994 by the Royal College of Physicians. You can see on this slide their statement about themselves, which is from their website. Since '94, the advisory group has developed and maintained standards in endoscopy by observing best practice across the UK, visiting all the endoscopy centres which are registered with them. Why is it important to be accredited by JAG? It indicates we've achieved a level of quality which we think is satisfactory, because it broadly equates to those better services across the country. It's also a requirement to be involved in bowel cancer screening, which is an important programme. JAG assesses 4 domains, is that slide there? Which include clinical quality, patient experience, workforce and training. The clinical quality domain looks at safe and effective diagnosis, treatment and ongoing management, and is principally related to leadership and governance. Patient experience encompasses the service's role in providing efficient and patient-centred care for all patients, which includes looking at waiting times, facilities and the environment. The workforce domain focuses on effective training and support for staff, including recruitment and retention and continued professional development. And the training domain reviews the support and development of trainee endoscopists, including appraisal and competencies. Services that do not provide training in endoscopy, those in the independent sector or private units, are only assessed against the first 3 domains. So the JAG process goes over 6 years with a full assessment, hopefully leading to accreditation, and then an annual renewal where data is uploaded to the JAG site on a yearly basis, and then the next assessment. That's a description of their pathway. So our last JAG accreditation before this was in 2018, and after that there were some challenges to deal with. We had COVID from 2020 onwards, which basically knocked waiting times through the roof, because a lot of clinical activity just had to stop or was severely slowed down. Along with that, and not long afterwards, we started the process of digital transformation at SASH, and within that single statement, there is quite a lot of complexity. Translating paper referrals into a digital model, along with the training to go alongside that and make use of it, was difficult and challenging, along with the processing and booking of endoscopy procedures and generating the outcome reports in a digital format, which also need to be sent to GPs. We still have little challenges with that system, but we're making good progress. Alongside that, one of the challenges was our endoscopy reporting software became somewhat defunct, got to its end of life, and the service that had developed it no longer existed, so we had to replace it with a new one, and that transition was a process in itself. We now have a system called Solus, and we're still tuning that up to our requirements. Alongside all this, in 2021, Professor Sir Mike Richards produced a document which is called Diagnostics, Renewal and or Recovery and Renewal, which looked at the diagnostics programme across the UK, and in combination with the national screening programme for colorectal cancer, made recommendations, which is all really to do with expanding and improving quality in endoscopy services. So we had to take some of that on board. There have also been changing guidelines with cancer screening, with reduction in the threshold of the test that leads to that, which is called the FIT test. And we need to take into account the expansion of our programme that will necessitate. So how did we get our accreditation? Well, we spent some time on it. Over 18 months, we had regular leadership meetings to set up priorities, work out what was required. We spoke to other trusts who'd recently had JAG visits, find out what was important, what they were being told, and we shared our workload out between all of the team, managerial team, the nursing team, myself, and other clinicians. And we prioritised as we went along. We listened to patient feedback, made changes and improvements. For example, we now have a what to expect video which is a thrill. Plays in our waiting room, and you can see by watching that what you might encounter when you come to our endoscopy unit. I like the statement, we made measured choices and put in sensible mitigations where our resources fell short of our aspirations. That sort of covers the experience we had when our scope cleaning system was basically put out of service at Crawley. So we had to come up with a way of supplying scopes for there at fairly short notice. And that involved buying lots of new scopes and a truck to carry them in. So that turned out to be successful in the end. These flexes that we have to do are often within our grasp. So we achieved our accreditation this year, and that has led to some improvements. We've looked at our audit processes, monitoring of key performance indicators of our individual endoscopists. We've streamlined our discharge pathways and equipment servicing, strengthened the pre-assessment process, and we maintain our ability to be part of the bowel cancer screening program. And we have developed a real sense of team within endoscopy. And Sean, our manager, is nodding with an affirmative that that's the case. As we look forward, our next accreditation process formally will be in 2030. And as I've already alluded to, we can expect that there will be need to be an expansion of the service to take into account the new requirements for screening. Thank you. I have to say, sorry, I'm now going to pass over to our improvement journey team, Sue Jenkins and Ben Henry.
Thanks, Alan. So afternoon, everybody. My name's Sue Jenkins. I'm Chief of Kaizen, and this is one of the few AGMs where you get a free Japanese lesson. So Kaizen means continuous improvement. And we've been working with Virginia Mason for just coming up to 10 years on our SASH Plus journey, on our improvement journey. The reason Ben and I are doing a double act, which sounds a bit odd, one doing improvement, one doing digital, is that we've recognised that, particularly over the last year, that most of our improvement requires some digital support. So we're just about to align our teams, are excited about bringing the two teams together and have a trust-wide transformation team, and we'll tell you more about that in next year's AGM. So in terms of our role within SASH Plus, so SASH Plus is a management system which enables Kaizen, so continuous improvement, to happen on a day-to-day basis for every member of staff across the organisation. And for us to be able to do that, we offer a number of training and development opportunities across the entire organisation. And over the year, we've touched 40% of the workforce just in 1 year through all of the offers that we make through induction, but also formal training and education sessions as well. So that opportunity enables staff to do improvement from a bottom-up process. We're giving people the skills to look at their own teams, their own services, and say, this is really important for us, and we want to improve X or Y, and it enables them to do that from a bottom-up perspective. So an industry of improvement across the organisation. Alongside the bottom-up, so building capability and capacity, we run a number of improvement events. And over the last year, on the next slide, please, we've run 9 rapid process improvement workshops and 3 Kaizen events. That takes a lot of resource from our SASH Plus team, who support people, a small team of people over a 5-day period to run an improvement event. We normally say we were going to focus on an inch wide and a mile deep and look at a particular issue and come up with improvements that we then embed over the next 30, 60 and 90 days following the event. Those events that are listed there cover clinical areas, but also non-clinical areas. And we've challenged ourselves to make sure that the work that we do, particularly in these events, are really focused around the strategic priorities and the breakthrough priorities or objectives for the organisation. So we're trying to enable the trust to focus on ultimately reducing waste, but we have shifted this year as well around reducing cost, recognising our financial challenges as a wider NHS, but also within our organisation. So that's the work that they've been doing over the last year. So when we talk about waste, we talk about 7 types of waste, and we use the acronym, that's the right word, a Tim Wood, to talk about transportation. So are we moving patients around the organisation when we don't need to? We talk about inventory. Have we got too much stock in our systems within our teams? And we have a dreadful habit of ordering too much sometimes just because that seems cheaper. But the cost of keeping extra stock is huge. So there's a waste that we go after. We look at motion. So are people stretching up, bending down, moving in all sorts of positions to enable to get the job done when they don't need to do that? We look at waiting, and that's waiting from patients' perspective, but also from staff's perspective, and also our resources. So if we've got rooms that are waiting for the next member of staff to arrive or the next patient to arrive, that's also a waste in our process. We also talk about over-processing, so doing the same thing again and again, because we don't believe that it's happened right the first time, or it just doesn't get done properly the first time, but also overproduction. And so do we supply too much of something and cause the impact of that is too much inventory? And then defects. So where do we not do things right the first time for patients every time? So we really ask staff to focus on those 7 types of waste. And our reflection is, once we ask our colleagues to put on their waste spectacles, it's really, really difficult to remove them. You start seeing waste everywhere. You start seeing waste in all parts of the hospital, but also at home, in airports, in Waitrose or Tesco or train station. You just start seeing waste everywhere. I've noticed even my children challenge me saying, "Oh, that's a bit wasteful, isn't it, Mum?" So waste is something that's a real core component of what we teach as part of SASH Plus, and is a key principle in terms of reducing that waste. So we've also got a responsibility to share our work. So we have 2 external contracts where we share our work. One is in partnership with Virginia Mason, who we kick-started this work off nearly 10 years ago. And we're working in helping East and North Hertfordshire NHS Trust to develop their own version of SASH Plus. And the second is independently, we're supporting London Ambulance Service to do the same. So we're just at the end of year 1 of a 3-year contract with London Ambulance Service. And the other way that we share our work is through open days. So we run 4 open days a year, and over the year we've had 90 people from across the country come and see and celebrate the work that we've been doing.
Thank you. So I'm Ben Emley, I'm the Chief Digital Officer, and SASH Plus and digital have worked hand in hand since our big eSASH project in 2022. And that continues to build, and we've already heard from Alan around how digital's part of our endoscopy journey, and for Sinead, I know you didn't mention it, but embedded in the frailty model and the work we do across the hospital. I'm going to give you a whistle-stop tour going back in time over the year of some of our digital highlights. Paul already mentioned the Sectra PACS Go Live, a long-standing legacy system that we've had for our radiology team, but also all of our clinicians. With it approaching its end of life, causing some frustrations, and I'm seeing some nods in the audience. But in February, we were able to go live with a new product, joining our imaging network and opening up our access and others' access to our imaging across most of the Southeast. A hugely successful piece with the digital teams and the clinical teams all working together. We decided in pretty much the same week to change our whole out-of-hours service for task management for doctors and nurses working out of hours and at weekends, and launched an EPR, our electronic patient record based platform for task management. Huge improvement in morale. SASH Plus tools embedded, and we were able to demonstrate how that released 11.7 hours, it's very precise, of clinical time every night shift, as well as improving the morale of all the teams that work. And now presenting that across the Southeast to medical teams. Can't forget the back office teams that help. And we launched during the year our online portal for digital support. I'll give a shout out to Mike Hewson, who has led that digital support team over the last 3 years since we embedded it and brought it in-house. And that culminated in us getting a runner-up, so still somewhere to go, in a customer service customer engagement award. And you can see in the picture us receiving that. Then going back a little bit further, one of the things that we couldn't do when we went live with SASH in 2022 was digitize ECGs. Our plan wasn't able to be executed, but we have done that this year, starting with a trial in ED, which went down very well with the clinical teams, removing some of the manual processes, but giving everybody access to ECGs in real time. But then we were able to take that to all the wards this year as well. Downtime, I don't really like talking about it, but it was a big piece for the year in terms of, in the previous year, we had a number of EPR downtimes, and SASH Plus teaches us those that do the work, improve the work. And there were lots of ideas that came out around how we can improve downtime should it happen. And we introduced some new downtime carts, reflecting some of the feedback, as well as the downtime boxes on the wards to help make that process as easy and slick as possible. And that takes us all the way back to the start of the year and possibly one of our biggest events, which is digital care pathways that Paul has already alluded to in terms of how that helps on our breakthrough objective around pressure damage. So this was a great piece of work, listening to users about the existing EPR functionality for an old assessment tool, Braden, which we were phasing out and wanted to move to a new tool called Purpose T. But building that into our electronic patient record was tricky. Users would not have liked it. So we designed a whole new functionality using some of the tools available to us, worked with our practice development team, our nursing teams, to develop the functionality and then deploy it. I think it was training 500 nurses over 2 or 3 weeks in both the new tool and the digital side of it. I did my training and just about passed the test. And that went live across the whole hospital on one day. Huge support from kind of everybody in the organisation to make that happen. But that paved the way for a number of other care pathways that bring us all the way back to the current. And we've rolled that out across mouth care, across nutrition, again linked to pressure damage, and also care of the dying adult. So kind of that functionality will continue to be rolled out, into more care pathways this year, as Sue alluded to, as the teams come together and we take the digital journey forward. Okay, I think I'm handing over to Mr. Simpson for the accounts.
Thanks very much, Ben. Thanks for that round of applause before we talk about the accounts. So the accounts were signed off by our auditors, KPMG, and they represent a true and fair view of our financial position. They didn't find any inconsistencies in our annual report, and we had something called the auditor's annual report, which is the value for money report, and I'll talk about that a bit in a minute, but that was also quite good as well. And finally, they did issue a referral to the Secretary of State because we're in deficit, because that's something that they have to do, and that's been sent off to the Secretary of State, and he has received that, but there is no further action that's following from that. Next slide, please. We did better than our financial plan in 24-25, but we are in deficit, so that's the clear point. And also to say, 25-26 will be the 4th year that we are in significant deficit. But that should not detract from the fact that we did deliver our financial plan. We did slightly better, actually, than our financial plan. But we do have an underlying deficit of £39.1 million, and the deficit that we delivered was £11.9 million. The graph shows the fluctuation in the trust's financial performance. So we were in surplus for a period of time, and then we've moved into deficit, although you will see that the underlying deficit has improved a little bit, but it's still a very large deficit. The reasons for our deficit are several-fold, and there are various drivers, is the word that we use, that are driving that financial position. So the first one to say is that before COVID, although the trust was in surplus, our the predecessors of the integrated care boards, the clinical commissioning groups, were in deficit. So we had a surplus of about just under £10 million. They had a deficit of £120 million. So that deficit has moved. Like many organisations in the NHS, we have employed more people and we are working more hours than we used to before COVID. But the amount of activity that we are delivering, the number of patients that are coming to us, has not increased by the same number. So that's affecting the amount of money we get paid versus the costs of the actual service. So there's a mixture of structural aspects to that and productivity aspects to that, and that's what the Trust is now addressing. So next slide, please. So we've agreed a 3-year period for a financial recovery plan. 24-25 is year 2, 25-26 is year 3. And we are in conversation with the Integrated Care Board and with South East Regional Office, which is part of NHS England, about how we do that. The discussion over where that financial recovery plan takes us is one of the priorities for the new Chief Executive coming in. So Andrew will be spending some time discussing that. And what we've now got is we've got some additional recovery support around that too. So there will be a recovery board that oversees the Trust's financial recovery, but also we'll look at the services that I said we provide in that very large catchment area, because that's one of the things that we're going to need to look at in terms of how we maintain our financial sustainability. And there will be a dedicated financial improvement director and a team supporting them that are being procured at the moment as well. So they'll be coming in to provide support to the Trust as we go forward in the next year or so. Next slide, please. And the auditor's annual report, which is about our value for money, it might seem like a very mundane and boring item, but actually it provides quite a good overview of the Trust's financial position and the steps that we've been taking to manage that financial position, and it's available on our website should you want to see it. So thank you very much. I think we're now all going to sit down at the table behind me, if that's the right thing to do. But also my thanks to all of the previous speakers as well. I hope that's given all of you a view of what 2024-25 was for us as an organisation, and just to highlight some of the things that the people have said there in terms of the things that we have achieved. So thanks to colleagues for presenting that. And if you want to know more, another document on our website is our annual report, which I'd recommend you also have a look at if you want some other information about what we've managed to achieve in the last year. So thank you very much.
Thank you. So now it's time for questions. Those of you who are online, please be aware that there will be a bit of a delay in the feed, so you won't immediately hear the answers. So if I can ask panel members to join me. Paul, you're sitting here. And in a minute or two, we'll ask the members of the panel to introduce themselves. If you have a question, please raise your hand, at which point a distributed team of the communications folk will be approaching you with a microphone. So raise your hand if you need a question. Without further ado, I'd like people to please introduce themselves from the end of the table, starting with Karen.
Good afternoon. My name is Karen Breen. I'm the Chief Operating Officer, and this is my third AGM.
Paul Simpson. I have introduced myself previously, but my normal job is the Chief Finance Officer, and this is my 18th AGM.
Hello, I'm Ed Chessie and I'm Chief Medical Officer.
How many AGMs have you done?
I think it's probably about the 5th.
Yeah, I'm Tina Hedrington. I'm the baby of the group. I'm the Chief Nurse, and this is my second AGM.
Not quite the baby, because this is my first AGM, because I've only been with the Trust for 9 months. And so now it's time for questions. There must be somebody to go first. Thank you. Gentleman over there.
My name's Laurie Reynolds. I was previous governor in the COVID period. I beg your pardon. Gosh, goodness me. Yeah, my name's Laurie Reynolds. I was a governor during the COVID period and for a couple of years after. Very interesting set of presentations. I've got lots of questions here, I'm afraid, just in case there's a silence when next time you ask for questions. The first one was about the frailty presentation. I was interested to know what factors you're measured against in order to move from the lower quartile, I think you said, to the middle quartile, and what factors are you measured against, and are you targeting the factors rather than necessarily the improvement of the service? A bit of a controversial way of asking the questions, perhaps. But also, I was interested in the close working relationship with the neighbourhood teams, and it seems to be very important that you identify factors which could prevent those elderly and frail coming to the hospital in the first place, and whether that's part of your measurement and reporting on progress.
Shall I make a start on that? So thank you for your question. The key measures that we measure ourselves against and compare with other trusts are some of the measures that Michael and Sinead mentioned. So that's the proportion of the elderly frail patients who attend emergency who are admitted versus the proportion that go home the same day. If they are admitted, their length of stay. And we know that crucially when we're thinking about outcomes for patients, those frail ones who are admitted, it's their length of stay and reducing that as much as possible is crucial at maintaining independence and crucially, as Sinead mentioned, increasing the proportion that are discharged back to their original place of residence. We know that staying in hospital is not risk-free for particularly those most frail and elderly patients in our community, with the risks of losing mobility, risk of infections, losing confidence, and losing independence, as well as the effects it has on cognition and your brain functioning. If you're in an unfamiliar environment and doctors and nurses are doing things to you and giving you medication with all best intentions, it can have real impacts long term on your cognitive abilities. So those are the key measures that we measure against, and those measures, as the team quite rightly said, have been successfully improving sequentially during the frailty service. And there's more to do because there are more patients that haven't had access to the service because it has a certain capacity. And we're now in that process of increasing the capacity to allow access for more patients to see even more improvements in those key measures.
I think the other thing to mention probably is also the importance of patient feedback, which was a metric that I believe the team mentioned. Thank you. That's fine, I've got them back.
And so you didn't actually give some of the quotes, I don't think, from some of the patients, but some of the quotes from patients and their families are truly inspiring about the quality of care they received and the care that staff gave them in the frailty unit. So commendable. And then you quite rightly asked about admission avoidance before someone even gets to the emergency department, and working with the neighbourhood teams, which is part of the NHS 10-year plan and a priority for all of us to work with community partners. We've been quite groundbreaking on, and before the NHS 10-year plan, on how our elderly care teams and the consultants particularly have worked with community partners and with primary care to try and wrap a degree of care around patients who are at risk of being admitted to hospital through multidisciplinary team meetings, often virtually with primary care, looking at those patients who are more frail, who have either been in hospital already or identified as being at risk of coming into hospital, and working out what can be done in the community to keep patients at their own home. That's been quite successful. There's been variations between Surrey and Sussex that we're trying to learn from each other, but that is happening, and there's more to do as we build up and the community builds up the neighbourhood health teams.
Could I just raise the service that's provided by Surrey County Council through Surrey County Council in Guildford Zero around energy audits, because I've been doing some of these energy audits in the area, and we're targeting the wrong people, I think, and we should perhaps be focusing more upon the frail and elderly in terms of improving the conditions of their home in terms of energy efficiency and therefore warmth, that they can put the heating on without worrying about the costs, perhaps, and how important that is in terms of a factor in preventing and improving the health management for the elderly.
You're absolutely right, and we know that the main determinants of health in community are not actually what we do in the hospital. It's about things like housing and social support. So you're absolutely right, heating in winter is crucial.
Thank you. And are there any other questions from the audience? Thank you. Please say who you are for us.
Hello, I'm Alex Ettelen. I'm the Associate Director for Performance Management at the Trust. And I have a question for Tina. Looking at pressure ulcer, a new breakthrough objective last year, we heard from Ben about the work that was done around digital transformation, but what were the other key improvements that you delivered to work on this breakthrough objective?
Thank you, Alexa. I think I definitely couldn't say there isn't one particular thing, but actually a whole host of things that I would reflect on. I would say actually keeping it as a breakthrough objective meant that we had a real whole hospital approach to improvement in relation to this area. And certainly what really struck me was how improving pressure ulcer care was something that became really meaningful for everybody across the organisation, whether you were clinical or not clinical. And so giving it the adequate focus that it needed was really important. Ben spoke about the digital solutions, which have been absolutely crucial in how we move forward and move forward with real pace. I think the partnership working that we undertook with Pioneer Health, who provided us with some additional resource and expertise in relation to training, product selection, was really crucial. But actually also, I think the two things that really stand out for me were around how we created communities for learning. So sharing learning across all divisions through our care counts and being able to rapidly mobilise actions that we wanted to take forward was a really important part. And I also wanted to, I suppose, really recognise the efforts of our colleagues within ED. They've worked tremendously hard around how we're improving our skin recognition within 4 hours. We're consistently performing at 100% of all patients doing that, and that's through sheer volume and hard work of the ED team every day focusing on this. So they're probably some of the top actions. There's a lot more beneath it, but it just proves how such a complex piece of work that the whole organisation has taken forward. Thank you.
Thank you very much. And any other questions from the audience? We have no questions submitted online, so if there are no further questions, one more, please.
I was disappointed that Sue didn't mention energy and water in your waste slide. For obviously speaking from a personal point of view, that's particularly critical, especially as I was also being invited last night to the all-party parliamentary group on net zero, Paul, and I'd be interested in an update on where net zero has got to. And also congratulations on the progress and planting of the, what I call 6-acre wood, which is coming along very nicely. I'm sure that's part of the positive news that you can give, but I'd also like to hear a bit more about the energy and water specifically, especially as we live in a water scarce area of the UK.
Okay. In terms of, so Laurie, you know quite a bit about our green plan. I know that. We're currently working, so our current green plan expires at the end of this year, and you will see a new green plan when the board receives that just before Christmas, and we're just working that up. We're lining that up with all of the new rules and regulations that we have to adhere to in terms of getting to net zero. We are on track, actually. We are delivering it. It's tricky, again, as you know, because not all of the energy issues are within our control. So we rely on gas and electricity from the national grid. So we therefore rely on where that comes from in terms of the green credentials. In terms of the bit that we can deal with, which includes the biodiversity, which is the wood that you referred to, 6.5 hectare wood actually is what it is, rather than an acre. So we're doing well in terms of anaesthetic gases, which is one of the key areas that we ought to deal with, and we're doing well with the other bits, but it's a relatively small part of it. We've got a priority which is over anaesthetic gases at the moment, and also in terms of how we're having more renewable access to the site, so people cycling, not just driving their cars, and also making sure we make better use of public transport. So we're doing all of those things currently. We thought we weren't going to be able to use £1.5 million from NHS England in respect of building a solar farm on this site so that we can actually generate our own power. However, we have been successful in securing that money subject to a business case that has to go through our processes, because we're going to put the solar panels, assuming the business case is approved, on the roof of the hospital, and we just need to check about how we do that. So we're very active in respect of our green plan and what we're trying to do. And we're also thinking, and Patrick, who is our Director of Estates and Facilities, we're also looking to drill a borehole into the car park, because we want to access water which is warmer on the site and use that, because if it's only a little bit warmer than the water that's coming through the mains, it will actually mean there's less need for energy to heat it up. And it will also be coming from, because we are in a valley and we are a very damp part of Red Hill to live in. So we're looking as imaginatively as we can at everything that we're trying to do. I don't know if that answers your question, Laurie.
Yes, but I just add a supplement though. I walked here, albeit only from Royalswood Park, so it only took me 10 minutes, but as a local community group, we would be very interested in participating in the sharing of the solar generation and the solar energy. And I'm also, because of my involvement with the HEAT program, the Home Energy Advisory Team, there's also a lot of interest in open communities and open energy in Surrey. And the Surrey County Council have available schemes that enable co-partnership, particularly for local solar generation. So I'd be happy to speak to whoever's responsible for that area if there's some interest in taking that further. You didn't mention water, Paul, other than the borehole. In terms of wastewater and water efficiency in the hospital itself, are there any initiatives going on in that area, please?
In terms of the usage of water, which is it's not a priority in the green plan, but we are making sure that we're making the best use of what we can do. So although it is another less pleasant part of water, but we are managing our sewage better. So one of the things that we've done in year is we've improved the sewage pipe. There were some major works that you might have seen, the disruption outside the hospital, so that we could connect our new wards properly, but also improve how sewage is managed across the site.
There's been a lot of opportunity for wastewater reuse in terms of washing, toilet flushing, etc. Again, too much detail.
We need to talk to you about that, Laurie, but and Michael White's got his hand up. He's obviously got a good idea as well, but Michael.
Sorry, it's not relevant. I'm not going to be able to crack that one. I had a question, if I may, just about, we talked quite a lot about some of the incredible work that happened in the past year. But that doesn't withstand how difficult some periods of it were, particularly over winter in last year, particularly in urgent and emergency care. And I just wondered for any members of the panel, but particularly with Karen in your role as Q, your kind of insights on the resilience that the workforce tends to show over winter with the things that people in the public might see on the news around corridor care and any
staff. And Michael, who's one of my team, will know, indeed, so will many other clinicians in here. I've been in the NHS 40 years, actually, and I've been at SASH for just under 3 years, and I'm staying here because of the incredible clinical, managerial and wider workforce that we have. It really is quite incredible, and we just heard snippets of what I experience every day in terms of the innovation, the resilience, the commitment for our staff to do more, do better, always looking to improve, enabled through our SASH improvement methodology, SASH Plus. So I think I wouldn't want that to be assumed. Really have a fantastic group, but winter is tough. And when I speak to clinicians and other managers in August, it feels that we're in winter. So I want to recognise that we are seeing increasing demand coming through our ED department. So everything that the teams are doing is important. And we're not in winter yet. So every year, and especially for this year ahead, we look to the clinical teams and we do a debrief. What went well last winter? What didn't go well? What do we not want to repeat? How can we make it better going forward? And this year in particular, we've looked at the evidence of things that Michael and Sinead spoke about in terms of SDEX and the absolute value added to patients and therefore the value added to staff by being able to do the best they can within the resources we have. So the plans for this winter build on that learning. So we will be looking to expand on our SDEC, our same day emergency care, not just across frailty, but across adults and children. Winter for Children starts 3 weeks after school in September, so next month. So we've looked at our plans around SDEC. We've looked at our plans around partnership working to build on the work we've already done around discharging patients with complex needs. We've looked at staff well-being. So we know that it's fair to say there was vaccine fatigue last year. So this year we need to do more by way of accessibility, by way of access to vaccinations as people are in work, and there's great plans going on with our Chief People Officer, and Deo's here as the Deputy. And all round, our values of being one team and treating our patients with compassion, but treating each other with some compassion when we will face some difficult times. So in summary, because we could spend all day talking about winter to come in September for children, we've looked at the evidence, we've looked with all our teams about what worked well, what didn't work well, what can we do better, and how can we further mitigate the risks that we have. Quite importantly, how can we understand those risks to our patients and really mitigate them with the fantastic leadership that we have. But it will be a difficult winter ahead of us. And I think we have a lot of clinicians in this room that if I said anything different to that, they would think I'm in a different planet. So it'll be difficult, but this is the team to make a difference for our patients.
Thank you, Karen. Are there any further questions in the audience? I see no further hands, and we've no questions, as I said, submitted online. So it's time for us now to close the meeting, but we close it first of all saying thank you to all of the fantastic work that's gone on in East Surrey Hospital, from all of the divisions and all of the clinical teams, all of the back office functions, but then to widen that out and thank our partners across the system, whether they're an ICB, an NHSE regional office, whether they're acute, community, mental health, or indeed ambulance trust providers, our colleagues in primary care, and the third sector. We've got two of our charities represented here with which we have a close association, Surrey and Sussex Healthcare Charity, and also the Friends of East Surrey Hospital. So that big, wide thank you, but more importantly, and thank you for your questions, Laurie, recognising that it is very important that we listen to our community, our population, whether you're a carer, whether you're a patient, or whether you are a member of the public. So thank you for joining us. And I'm just also going to say thank you to several people who aren't here. And that includes Paula Swan, Non-Executive Director, Yasmin Khan, Non-Executive Director, both of whom have left us during this last year, to Richard Shaw, who served this trust as chair for 12 years, and to, finally, Angela Stevenson, our Chief Executive, who after 37 years of service to the NHS has taken early retirement. So thank you to all. We move forward into the next year with a new Chief Executive Officer, Andrew Hines, who will join us on the 1st of September. So a year of new challenges and renewed vigour. And thank you very much all for joining us. The meeting is now closed.